I think you can start, Mr. Mahmoud.
I'm just waiting until it's exactly sharp 4 as a Swiss time.
Okay.
Yes, of course.
Yep.
10 seconds to go.
So, hello everybody, good morning, good afternoon, good evening, wherever you are, to everyone around the globe. Welcome to this MOH Connect, as we have been doing this for all over 2024, actually started also in 2023, with Dr. Erika Mendoza from Germany, from her clinic, where we have a real life cases sharing her expertise and knowledge. As you all know, the goal from the MOH, the Medical Online Hub, is actually to bring together medical experts from around the globe. That's why we have today with us Dr. Elena Montero from Spain, one of the most famous experts also on the wound care, and of course with the great moderator, Professor Dr. Muhammad Omar El Farouk from Egypt. So as we always looking to have the discussion and also exchange in the state-of-the-art topics in the field of the venous-lymphatic disorders, today we are focusing more on the wound, venous ulcer, lymphatic ulcers, and also the role of the compression. As you know, at MOH by Sigvaris Group, we're always looking for bringing top-notch expert and scientific discussions based on evidence to make sure that we are sharing educations everyone everywhere. If you look at the MOH platform, you will see different content. So we have been building all this content, not by us, it's actually built by you and to you. You will see different format, webinars for 1 or 2 hours, short interviews like MOH Essentials, or live on a stage or live cases from clinics as the MOH Connect. But also we do some abstracts and also focus, MOH Focus, where we bring some conclusion from the running studies, even if it's against using the compression. This is what we always do. And in a personal note, I'm really looking forward to some dynamics and lively discussion and the interaction. Having said that, I will have the pleasure again to introduce our principal moderator, Professor Dr. Muhammad Omar El Farouk, consultant vascular and endovascular surgeon from the Royal College of Surgeons of England. He's also examiner there, but basically Egyptian as me. But yeah, he's specialized in advanced endovascular and also open surgery for critical limb ischemia, diabetic atherosclerotic disease. He also has extensive experience in complex endovascular surgery of aortic aneurysm, lower extremity occlusion, as well as hybrid surgical technique, and more, of course, with the varicose vein dialysis cases. And Dr. Omar have done a lot. It's really hard to catch up, see what he's doing in education with his own platform, the Vascular Online Training, where you are also different things up to the AI intervention in the venous-lymphatic world. So he was actually graduated from Ain Shams University in 1983, completed his postgraduate training at West Midland Vascular Rotation in UK. He obtained his fellowship at the Royal College of Surgeons in England, 1994. And after that, he completed his training and joined the General Organization of Teaching Hospitals and Institute in Cairo, Egypt. So Mr. Muhammad Omar has also have interest, including in education and simulations and designing different modules and treatment protocols. So a lot of publications, a lot of papers. I cannot stop, continue reading his achievements. So with that, I would give the stage to you, Dr. Omar, and thanks again for everyone joining us. My name is Mahmoud Al-Ghadban. I work at Sigvaris Group in the headquarters in Switzerland. Not my first time with you, but I'm always having the pleasure to be here. So to you, Dr. Omar.
Okay, thank you very much. And we always have the pleasure of having you with us, because MOH was totally your idea and your genius idea. I'm very happy today because I have 2 stars, 2 of the best phlebology stars all over the world. Not only that, but I'm happy because we have really difficult problem for all phlebologists, venous ulcer. Venous ulcer is a worldwide disease. We all know the impact on economy, impact on the country, impact on the spending, impact on companies, and even impact on the patient, because the quality of life drops dramatically. Some people compare it to cancer, GIT cancer, if you have venous ulcer. So difficult problem. 2 stars have great ideas and great pioneer. Let me introduce them. Though obviously they don't need introduction, but I will just summarize to the newcomer. We have Professor, my dearest Erica Mendoza. Anyone in phlebology must have learned a lot of tricks from her. Erica Mendoza is one of the most famous phlebologists all over Europe, and she speaks German, Spanish, English, and little Italian as well. And she has been a phlebobologist with a big enthusiasm toward Chiva procedure. She have so many international activities. She was the president of the International Phlebology German Society, and she also president of the International Chiva Congress in 2012. And she has so many contributions. If I go to the chapter of books that she has already invented, there is so many books, just a few to mention, just books on Chiva, and books on venous intervention, and books on duplex scan. And she had a huge amount of publication. I can go on and on, but I want you to benefit from her tips and tricks. And our star is Dr. Elena Condi Montero, a dermatologist consultant, again, one of the very eminent, with a special technique that we'll all see, which is an excellent idea that will save us a lot of money for treating venous ulcer. And she had a degree in psychology. And this is very interesting. And she had a dermatology consultant in Madrid. She worked in Hospital University Infanta Leonor Vergen de la Torre. I hope my pronunciation is acceptable. Spain is a lovely country, and I've learned a lot from Dr. Zell. And she also is a member University of Paris. So here our 2 stars. Here is our problem. I'm very excited, eager to learn a lot from this webinar. And the mic is yours, Professor Erica Mendoza.
Thank you so much, Omar. I'm ashamed. You shouldn't say all these things of me. This happened like the years passing by. And I'm very, very happy to be here. Thank you to Mahmoud for having the idea, and to Sigvaris for allowing this platform. And for you, you are a wonderful moderator. This has to be said. And just stop making ourselves wow-wows. I would like Elena to start with her wonderful method. I learned it in a meeting in Mallorca, and I said, wow, this is really a great idea. It had to come from a Madrid girl like me. We are both Madrid girls. So Elena, bienvenida, encantada, and the mic is yours.
Muchas gracias. Thank you very much. It's a pleasure for me to be here with you. Let's hope this is a very interactive session. I'm prepared for all your questions. I hope that my presentation is very practical, so I will start sharing my screen. I've decided to put this title because I want this to be really practical, and for you to know the tips and tricks to start tomorrow or even today, if some of you have the possibility. So when will we use this technique in a leg ulcer? When we have a correct diagnosis with the adequate etiological treatment, and the wound needs our help to epithelialize. So there is nonsense if you treat an ulcer with punch grafting without having treated previously the cause of the ulcer. So you have the perfect compression therapy, or you have treated the reflux in a leg, and the ulcer is not responding as you expected. This is when you have to graft a venous leg ulcer. But however, there are other situations where you see the ulcer and you say, I'm going to grab the ulcer now without waiting. So now is the moment. So which situations are those? The so-called mixed ulcers, those ulcers that are predominantly venous leg ulcers, but they have a component of peripheral arteriopathy. This is perfect because punch grafting not only promotes epithelialization, but it also reduces pain, and in these patients, this is an issue. When you have atrophy blanche, just remember that chronic venous insufficiency is the first cause.
Just a small question. Are you moving the slides, Dr. Elena? Because we can see only the introductory slide. We don't see the presentation slide moving on.
Okay, so I'm moving the slides, so I don't know what's the problem.
Maybe if you present on F5 or present, it will go into PowerPoint mode. We can see just one slide, which is the beginning.
I will try to share again. Just one moment.
Yeah. Okay.
Maybe you can start the slideshow.
Let's see.
Elena, lo que tienes que hacer es abajo, ahí, exacto.
Sí. Is it okay now?
No.
Yeah.
Tienes que apretar
No,
tienes que apretar esa tecla donde estás justo, donde está el arrow, joder, ahora no sé hablar español. Where the arrow is, this is the correct one. O abre la presentación en paralelo, de
Vale.
full screen, y luego
Perfect.
haces otra vez.
Perfect.
Ahí sí, ahí estás en sitio correcto, pero no funciona, ¿no?
No.
Y si vas a vista, vete arriba en la línea a vista.
One moment.
In the heatings. Si haces lo que intentas hacer antes de sharing.
So,
First open the whole image and then share it.
let's see.
Oh, sorry.
I think that maybe this can be the solution. Let's hope it is. Like that?
No, we see your complete screen. Do you see the word vista? Revisar, es inicio, insertar, revisar, vista. Si vas a vista, puedes abrir presentación.
Let's see. Yes, here.
Mm-hmm.
And like that? No. So
I think you have to do that when you are not sharing and then go back to sharing.
But
I mean, we can see it like this.
I can do something from my
maybe
side.
now?
See the screen and move the slides for you, Elena.
Sorry?
I can share from my side and move the slides for you. You can
Perfect.
just tell me next
Let's
and
do
then I
it
move
like that way.
Okay, if Dr. Elena, if you stop sharing, then Dr. Mahmoud will be able to share the same presentation, and you can mention next. I'm sure it will go nicely because it's such a fantastic,
Perfect.
important. That's it. We're on the go. You can say next, and then we can proceed.
Okay, perfect. Well, as I've told you before, it's important to have previously the correct diagnosis and etiological treatment. Next. So punch grafting will promote epithelialization. So we are going to pass the slide like that because as I've told you, if a venous leg ulcer is not responding either to compression therapy or after treatment of the reflux, you just go with punch grafting. But when you just have to perform this procedure when you see the wound, next, is in this situation, the first situation is when you see the so-called mixed ulcers, next. These ulcers are very painful, they are hard to heal wounds, so even if the wound bed is terrible, just go ahead grafting. Atrophy blanche, this ulcerated atrophy blanche is very painful. So we go to the previous one. So chronic venous insufficiency is the most prevalent cause of ulcerative atrophy blanche. So go ahead grafting these atrophy blanche. And for the so-called martorell leg ulcers, these arteriolosclerotic ulcers that are so prevalent in the elderly patients. So when you see all these cases, just graft the wound when you see the patient. Because in traditional books, when we talk about skin grafts, we think of a perfect wound bed. You have the perfect wound bed with adequate granulation tissue, the bacteria burden is controlled, you don't have exudate, but this situation, this never happens. So the perfect wound bed will be never there. If the wound bed is perfect, you will just put the grafts and everything will go very nicely, but this is not reality. Next. Reality and practice don't get on very well. So what we have in the clinical practice is wounds with a suboptimal wound bed that we have to graft. And this is interesting because this is the same patient with a suboptimal wound bed on the foot and a very nice wound bed on the leg. Both wounds epithelialized in the same 6 weeks. So in our clinical practice, we see that it's not that important to have the perfect wound bed. And if you need to regraft, it's not a problem. So let's continue. So this is the procedure you are going to do. Play. So you do it in your office. You don't need sterile gloves. You just put topical anesthetics, and then you go to the papillary dermis. This is a split thickness skin graft. Is like a mesh graft. You just see this point-size bleeding. We are going to see the video again, and then you put the graft directly on the wound. Here you see the point-size bleeding, which means that you are in the perfect depth. And here you see all the grafts spaced out, some millimeters, one from another. And I say also always that for small wounds, small grafts, for big wounds, big grafts, and you can space them more. So this is the material we use for taking the grafts. It's zero high-tech material. We use infiltrated anesthesia, either lidocaine, mepivacaine. If we have big ulcers, we will use a bigger donor site, and we will put 50% lidocaine, mepivacaine, and 50% physiological serum. Just to use less anesthesia, you have to put it very superficial, as you are just going to the papillary dermis, and you see again there this point-size bleeding. You can take this graft with a punch, with scissors, with a curette. I just prefer directly the surgical blade and with the pincet. We are going to continue with more photos and videos. This is another video. We will just put the anesthesia very superficial. You can see there the swollen dermis. You don't need to go further in the subcutaneous tissue because you are going to go very superficial. And you know that you are in the correct depth because you see this point-size bleeding, as you see here. If you go further, if you go deeper, no worries. You are going to see a deeper bleeding, but you are going to re-put the graft without any problems. And then you can help yourself with like that to put the graft, or you can also use another surgical blade to help you to put the graft on the wound. You will space the graft some millimeters apart. And once again, this point-size bleeding. Yeah. So which is the dressing that we use for the donocytes? The donocyte is the wound that we are going to go to the previous one, the wound that for which we have more research, more studies, and the conclusion is that no dressing has shown superiority to others. Why in our clinics we always use alginate? Because alginate has calcium, it helps to promote coagulation after the procedure. And if you maintain it for 3 weeks on the wound without touching, you will have like a natural scar because acute wounds heal in 3 weeks. So that's the way of putting a dressing without having to change it. So let's continue. That's why I put here these 3. Remember, 3 weeks for superficial wounds, you don't need to touch it. And 3 weeks later, it falls as a scar next one, with complete epithelialization. So sometimes for extensive donor site, when you have lots of bleeding, some bleeding, you may have this, we continue, some inflammation, some erythema. This is not infection, and this is too much inflammation, because inflammation is a normal part of the healing process of acute wound. We just treat this with some zinc oxide and some corticoids, and it solves. So no problem if you see this, don't worry, and put some corticosteroid. And regarding the grafted area, here we don't know which is the best dressing, because there are no studies about that. We also use alginate. Sometimes we use an interface, but what we always use is compression therapy adapted to the patient. Different devices may be used. Afterwards, Erika will talk about these different compression devices. And it's very important to tell the patient to have some immobilization. That's why we recommend thromboprophylaxis with enoxaparin, 40 milligrams, and we recommend immobilization with elevated legs. The problem is that the elderly, it's difficult to recommend them not to move from the bed. Bedridden patients have the problem of losing muscle. So we just adapt this immobilization to the patient needs and comorbidities. Let's continue. Sometimes we help the grafts to get attached to the wound with negative pressure devices. When do we use these devices? When we have previous graft failures, when the wound is deep and the tissue is really suboptimal, when we have ulcers in areas where we shouldn't put pressure on it, such as the Achilles tendon, on bony prominences to avoid more damage. That's a good solution to help at a graft attachment without putting too much pressure there. Let's continue. In fact, this is an example of an ulcer that had been previously grafted without complete epithelialization. We regrafted the wound, this time with negative pressure, and we achieved complete epithelialization. As you can see, we put barrier cream around the grafted wounds, because a wound after grafting will be more exudative. So that's a way for protecting the peritoneal skin. We are going to continue answering questions that can be in your mind. So for us, the most important point is immobilization with elevated legs. And the longer, the better, but adapted, obviously, as I said before, to the age and comorbidities of the patient. We continue. So how often do we change dressings in our patients? So this is my dog. I adore putting, he's 15 years old. The more spaced out the dressing changes, the better. So if we can do dressing changes every 2 weeks, we are not going to do them every week. Or if in some cases, if exudate is controlled, we are going to space out dressing changes even it's 3 weeks. So this is an example of a very extensive ulcer with both arterial sclerosis and chronic venous insufficiency. Just think that in the elderly, pure ulcers, pure venous-like ulcers are not that common, and arterial sclerosis is very frequent. These ulcers are very painful. So we grafted these wounds. As I said before, for big ulcers, big grafts, we put the grafts, as you can see in the photo. You see these are big grafts. We spaced out them. And we covered all the wounds, and the dressing changes, the following dressing changes were every 2 or 3 weeks. We put the compression bandage adapted to the needs, and then every 2 or 3 weeks, in fact, in less than 2 months, this wound was healed, but we just saw that scabs were starting covering the grafts. We didn't touch the grafts, the scabs. We just re-put some zinc oxide lotion in every dressing change. We just did 2 dressing changes, and we achieved complete epithelialization with scabs less than 2 months later. So wounds heal with scabs. In our clinics, we create scabs. We try not to touch those wounds that are having a good evolution. Here is the patient with the healed wounds, but the most important thing is next one, controlling chronic venous insufficiency, continuing the control of the etiology with adequate compression therapy. Let's continue. So the pearl in our clinics for once we've grafted a wound, and for in general for those wounds that are having a good evolution, is, and we continue, not to cleanse or not to debride. We just don't touch those wounds that are having a good evolution, not to impede the wound healing process. We continue. And what do we put to help epithelialization? We may put some zinc oxide lotion in every dressing change just to promote that epithelialization of those grafts that are in the wound, either attached or non-attached to the wound, as we will see. So because zinc oxide, for you to know, is anti-inflammatory, antimicrobial, and it promotes epithelialization. And sometimes we just look at the dressing and we don't touch anything. This patient has been grafted. No, let's go to the previous one. Just imagine you just see an alginate that is dry and is attached to the wound. The patient has no pain, no edema. Why are you going to get rid of this alginate, which is a matrix, which is the scalp? We just let it there. We just wait another 2 weeks, and sometimes you just see the scalp and the wound is epithelialized. So let's continue. That's our motto: not to touch if we don't need to. And sometimes we just look at what is happening there. We just put the video. We are, the alginate is attached to the wound. The grafts are attached to the wound and the alginate. We just re-put the alginate. Nothing has happened, and it will act as a scalp. Let's continue. We just re-put it, and 2 weeks later, we see the patient again. So this is the color code you need to know if you start grafting. So let's start. We may see all these colors. When you see the wound pinkish or bluish, these are nice colors. When you see colors that are black or yellowish, they are not that nice, but the message is that you don't need to touch anything. Leave everything in place. We continue. So when we see purplish color on the graph, this does not mean that they are necrotic or they are going to be necrotic. This means that new vessels have been formed, but these vessels are immature. We have venues that are congested venues, but this is a very nice sign. So we just leave it, everything like that. We don't touch anything. And in the fall, let's continue. In the next dressing change, just imagine 1 week or 2 weeks later, we will see those grafts that were previously bluish or purplish, more pinkish. So these venues are now mature. They are not congested. This is the normal evolution of neovascularization. So pink is a very nice color. Sometimes we see the grafts with this whitish color, which means that no new vessels have been created, or well, maybe here you see some points, some red points in some whitish grafts, and we just let it in place because, as you see in the next slide, sometimes half of the grafts are pinkish, half of them are whitish or yellowish, but in the following dressing change, you see that those that were whitish or yellowish now have new vessels, are purplish. So yes, have patience. Sometimes the problem is that those whitish or yellowish grafts will never be attached to the wound bed. These jelly grafts will just, they will continue delivering growth factors and interesting cells, but they will never get attached to the wound, but just leave them there. The most interesting dressing for a wound is that dressing that has fibroblasts, keratinocytes, and other human cells. So you just leave it in place. And when you have the scab, this means that epithelialization is completed, and you just let the scab be in place until it falls. So this is, now that you know this cold color, you can understand how this 3-year, this ulcer of that had a 3-year duration was grafted. And as you can see, 1 week later, this is what we see. Next slide. Some grafts are attached, others are not, but we leave everything in place. We space out dressing changes, and we achieve complete epithelialization in 7 weeks without touching the wound during dressing changes. So let's continue. When we have tendon exposure, punch grafting is very interesting too. The first line treatment for tendon exposure obviously is a flap, but surgeons normally don't perform this procedure on very old patients. So to protect a tendon, putting skin grafts is the most interesting thing to do, because the skin will protect the tendon, and as you can see in this case, we put the skin grafts there. I'm not telling you that skin grafts will be attached to the tendon and close like that, but they are going to promote granulation tissue to contract the wound, and in this case, we achieve complete epithelialization. This is not the most common. The most common is that you have to regraft. When you have tendon exposure, you have to regraft every 3 weeks to continue protecting the tendon and achieving complete epithelialization. But just think about punch grafting and negative pressure when you have tendon exposure. And let's continue. And sometimes you just have to get rid of everything to let the grafted wound stay open air to avoid maceration. Because look at this case, once again, ulcers due to arterial sclerosis and chronic venous insufficiency in an old lady. We grafted those wounds without previous debridement. We don't debride wounds in patients with arterial sclerosis. Let's continue. We spaced out dressing changes, but this was the result. Grafts stayed macerated. We couldn't control that. What we did, we just put the patient with elevated legs, open air, without dressings or bandages, just with zinc oxide lotion to dry those wounds. And in less than 2 weeks, we had this complete epithelialization. So think about when you have that maceration that you cannot control, putting patients with elevated legs without dressings and bandages, and the skin, the grafted ulcers will dry. So if you want to know more, well, now we are going to solve your questions, but here is my website, where this is my book, where you have more tips and tricks to perform this technique.
It is excellent. It's really very, very impressive, your slides, and it is so simple technique that can be done, as you mentioned, by today with local anesthesia or clinic. I got a lot of comments, superb results. And we have one question. What is your preferred donor site for these punch graft? Is it the thigh or the arm or abdomen? What is your preferred site?
My preferred site is the anterolateral aspect of the thigh. This is the place where you have less hypertrophic scars. In some patients, we will have to go to the arm or to the abdomen for other reasons, especially in patients in burn patients. But if you, I mean, the first line area is the anterolateral aspect of it.
Excellent. I got another question. Yes, please, Erika.
I have a question. I'm, as always, wonderfully surprised with your results, but I can't imagine leaving the thing 3 weeks, because isn't this itching and isn't it smelling, and aren't the people complaining with that?
Thank you for this question. Obviously, when you have a wound or even a leg without a wound that is covered with a bandage, the temperature will increase, and bacteria like Corynebacterium that are associated with bad smell will proliferate. What do? Those wounds that have more exudate that we cannot control, those wounds will come every week, of course. But in some patients, especially elderly patients that cannot come to the clinics and we have controlled exudate, it's not that problem. We use a lot of zinc oxide bandages. Zinc oxide, it has antimicrobial properties. We reduce Corynebacterium. In fact, the first deodorant had zinc oxide in its composition, and it helps a bit for this other, but really for patients, this is not a problem. And itchy, that's also interesting, as we use lots of zinc oxide bandages. It has anti-inflammatory properties, it's not a problem, and we try to moisture a lot the leg before putting the compression system.
Moisture with what? Because I use zinc oxide bandages for phlebitis, for superficial, for people with inflammatory pain in the leg. And they tell me, especially in summer, that it starts to be itching after 3 or 4 days.
In fact, if you just put zinc oxide will just dry the leg. So if you put it on those patients that have itchy skin, you can put half moisturizer, half some corticosteroid cream, and you just put it on the leg. And moisturizers normally have Vaseline or some oils that will protect that skin. That's it. So
you are a dermatologist. I'm a stupid phlebologist. Moisturizer means oily things.
Yeah, that's it. Moisturizer, and especially for people with dry skin, you just need products that have oil or Vaseline as a base, and afterwards some ceramides and other kind of fatty acids that will help. Okay. And also you will have urea or glycerol that will give some water to the. But if you use creams in the elderly for dry skin, you don't need just urea or glycerol to give water to the skin. You need to protect that skin from losing that water with oily products.
Okay, so when I make a punch graft, I will protect. First, I put something oily, and then I put the zinc oxide.
That's it, because zinc oxide barrier cream is also oily. It's Vaseline, so you can just do it that way.
Perfect.
Thank you. I got another. Yeah, please.
You had questions from the audience. Sorry.
Yes, I have another question regarding compression. Which type of compression would you use? Would you use grade, which class 1, class 2, class 3? And if the patient, let us say an old man, and you don't feel the pulse is very good in the foot, so what is your compression policy after such a great procedure?
So regarding compression systems, we have several devices, multi-component devices. You can also have short stretch bandages, or we use a lot of zinc oxide bandages. I have to admit that. When we use negative pressure devices, we always use compression therapy, and we will use multi-component compression systems, which will help to maintain that in place. And regarding your second questions, was what about policy? Yes, could you?
If the patient is little bit ischemic, okay. So borderline ischemia, do you still do compression, and which pressure would you use?
Okay, perfect. In fact, we even graft patients with peripheral artery disease that have wounds that cannot be revascularized. They are arterial ulcers, and we do it in a palliative way. We just put the grafts to create a scab just to reduce pain. In those cases, we don't use pressure. We just put the grafts there, and sometimes it's amazing how pain can be reduced. And as we don't touch the grafts, we can create scabs on those very painful arterial ulcers. In arterial ulcers, we don't put any pressure, but in those so-called mixed ulcers, we do is we adapt the pressure to the patient, and sometimes with these zinc oxide bandages, we just put, for instance, just one bandage, and the pressure, won't affect the limb.
Brilliant. I will take one last question from Dr. Edwin Stefan. An excellent presentation and excellent idea. Have you noticed the changes in the extent of graft update in heat and humid weather? So if you work in a country where you have a lot of humidity near the sea, like in Spain, little bit of hot weather, does this affect your results?
This is interesting. I live in Madrid. We have very extreme temperatures. In summer, it's very hot, but it's not that humid. The problem is that when you put compression therapy, or when you occlude the skin, just because of occlusion, even if you live in dry countries, occlusion will macerate the skin because of augmenting the temperature. So what we see in my clinical practice is it does not depend on summer or winter, because in winter we have patients that are at home with high temperatures too. The thing is that we see that with occlusion, sometimes we do not deal with maceration on the grafting room, so we just have to put less elevated legs opener. So in these very humid countries, maybe the solution would be to put pressure, to put the bandage for the first week to promote a graft attachment. Graft attachment will occur in the first 3 or 4 days. And afterwards, just to let those wounds to be opener with lotions that can dry that new skin, because the skin is not prepared for being dry, for being moist. Skin is prepared for being dry. So maybe in those humid countries, the solution would be to continue with elevated legs and dry lotions of the graft.
Excellent. And I would like to thank you personally because I have listened to your lecture in the German Phlebology Congress 3 years ago and started to do punch graft in my clinic. And I can't tell you how impressed I am with the relief of pain that happened on the same night you do the punch graft. I haven't seen this with any technology. So this is a special thanks coming from me. So great lecture, great question, and the mic is yours, Professor Erika Mendoza.
Thank you again, Elena. As always, impressed with your idea and with the results. So I will share my screen and start just very little of theory, and then go to a patient, a very lovely lady I have here with me. Of course, this activity is sponsored. So why compression in ulceration? Because we have, for example, varicose veins filling the place here. So this high pressure goes down. And the first step, and always step, if we have an ulceration and it is a venous ulceration, we have to put compression on the leg. And the German guidelines are very clear and say you need knee-long compression, and you can put the other if you want, but as the compliance is higher, knee-longs, it is very important to use knee-long, because ulceration never will happen in the thigh. It will always happen on the calf. So which options do we have? We have bandages, we have compression stockings, we have Ulcus-Stocking systems, we have medical adaptive compression systems. And we will show you one of each or two of each, and show you how to do it and which are the pitfalls. We have several types of bandages, and it is very clear: do not put the raw bandage on the leg. This was in the earlier times when we did not have all these wonderful things we have today. Because for the first, if you make a double layer bandage, it will not go down. It will adapt to volume changes, and it will not hurt the skin, because you have a soft underlying bandage. Like if you really want to use this kind of rubber bandage, you need to put something soft below. But the German guidelines are very clear. This one is obsolete. We need something double layered. Do not spare material. This was a lady with, very creative. I do not have to comment on the nonsense of such a bandage. But this was a lady bandaged with a double layer system by a technical a lady going there. She was supposed to be a nurse. But of course, this is not good. And I never know if this happened because the patient unfolded and put it again, because I can't imagine this to be done by a professional. And you see this very profound furrows. There is a pressure place which could provoke a new ulceration here. And the start was done like at a point where beyond the toes, and this is favoring a big edema in the toes. So this all should be avoided. Do not apply these things to the leg. And this is one of my highest, I don't know why people are so stupid. How can you pack this and then tell not to use these metal clips? Please do never use metal sharp things on a leg, especially if you are trying to get rid of lesions on the skin. So this is really something I don't understand. We have these wonderful multi-layer systems of different enterprises with different helps. I will use one where there are the soft bandage is cohesive, so it won't. If I apply it, it won't go away. And You have to always be aware to have a 90 degrees ankle in the foot and to do it overlapping. And then you have a second layer, which is adhesive. Never put adhesive layers on the skin. You can put cohesive because they adapt to themselves, but adhesive to the skin is not good. And then you have, when you finish, you have a bandage which will stick like 2 or 3 days, depending on the volume change you will expect on the leg. But normally this is really, really good placed on the leg. And so now we go to the demonstration. I was told to stop this. I remembered. And I go, and here we have the leg of Leonie. Leonie is a young lady, very healthy, but we painted the varicose vein, the skin discoloration, and this black thing is supposed to be the ulcer. Everybody sees the ulcer. This is our friend today. And we want to do lots of things with this leg to get rid of the ulcer. Of course, we could start making the punch, but I think I won't do this to my friend Leonie today. So this is the double layer system. This one is from Hartmann. This is the cohesive. It is not adhesive to the leg, but it is adherent in itself. And you have to tell the patient, shall we say like we make like this? Is it better to be seen? Yes? Okay, we start at the line of the feet. We don't put the first line below the feet because of course the patient will be walking on it. And we start with some, of course you should do better than me, 90 degrees. There are lots of schools how to do this. To make first like this, being careful not to make furrows here, and go back to the ankle and down to the foot. The thing is, when you start, the foot has to be covered properly. This region has to be covered properly. It shouldn't be open. And the good thing with this cohesive bandages is that even for a person not used to do it every day, like you will observe, the bandage will stay in place. And now we go on going up on the leg. This part of the bandage is not so stretchy. It's a short stretch bandage. And it is important to roll up the bandage on the next to the leg, not make like this and then like this, but doing it directly on the skin. First, you avoid furrows, and second, you have a better feeling how it goes, how it runs on the skin. This one is not so important to make it stretchy because it's just also a protection of the skin. And the enterprise says, if you are strong, there is a scissor, da ist eine Schere oben drauf. Oder nicht? Genau, da unter dem I'm not strong, I need a scissor. The camera team is very, very versatile. They help also with the scissors. And it is cohesive, it will stay like this. And then you go, this one has a longer stretch like the other, but it is still a short stretch. And it is idiot sure safe because you have to convert this rhomboid things into like nearly round things. And you start again next to the foot, and you should never go like this. You always should leave a little bit of the white to avoid this adhesive thing directly on the skin. And again, the foot is always the difficult part. You go up and you go down again. The problematic thing with these bandages is that to anchor them on the foot, they will not fit inside a shoe if they come with normal shoes. And I learned from Professor Parch, whom I really loved, that you can use stockings, normally if the patient has an ulcer here or has a real big edema on this part of the leg, and he has already a stocking, you can put his stocking and make the bandage over the stocking, starting like only here. And he told me, like 10 years ago, and since then, if people comes with little tiny shoes, and I want to start treating them, this was not good, then I use those stockings as the first layer and then go with my bandage on them. And if they resist and the bandage is not too strong, you will have a good result. This one is supposed to be a 25 to 30 millimeter Hg pressure if you convert these ones into round things. So don't make more layers than necessary. Here again, it's supposed to be able to cut it. Here you never put, please, these metallic things. You can put, you can apply, I'm not prepared, you can put this tape. Oh my God, my English. Like telephone, you can put it here, but it will also stick. You see, I say the camera team is perfect, and I don't know the name of this in English. I'm sorry. Okay, the patient can move a little bit the foot, but as Elena also said, it is important if you have an ulceration that, for example, the movement is less in this moment, just to avoid the frictioning of the surfaces. How are you feeling with this? Great. She's feeling great. You have to look at the toes, with the other one here, are not different color. This is very important when you finish, because if they start to be white or dark blue, it's obvious that the thing is too strong applied. Yes? So this is the double layer bandage, and this is usually the thing to start with, because when you are in an office, normally you don't have a complete battery of all compression devices in the correct fixing. And the second thing is that if you have a very swollen leg with an ulceration or without, and you put any device on it, you will have to get a new device or a new stocking when the volume has reduced. So the correct way is start, in case of a real large edema, start with the bandaging, and you can leave it some days, as we heard from Elena, you can even leave it 3 weeks. But my experiences, I mean, in Germany, the guideline says if you have a lymphedema, you have to make the complex treatment with everyday lymph drainage and bandaging and so on. I do not find any therapist who gives me lymph drainage daily tomorrow. We have to wait for months sometimes. So my solution is, I make this and ask the patient to come back next day if the edema is soft. And normally they lose like 4 centimeters at this point and 3 to 5 centimeters at this point. And then I start adapting in combination with the orthopedic enterprise, a stocking or a wrap or whatever we will plan. So now I leave my assistant. I will introduce Britta. Britta is a wonderful worker of Sigmaris. She's visiting me since 15 years, I think so. Britta, sieht man nicht? Okay. And Britta will unwrap the leg while I introduce you to the next step, or we can discuss this. And please remind me that I have to put, I forgot to put a wrap on the ulceration. I have to do this with this next one. Okay, so we are back here. Any questions to the wrapping?
Excellent. Thank you very much for a great demo of wrapping, a lot of tips and tricks that we have seen with the two-layer bandage. I have a question here. Someone asked, when you wrap the bandage, how much do you cover the previous bandage? Do you leave 1/3 exposed or 1/2? Because you did have very nice way of wrapping it.
Yes, I just try to leave, I mean, well, 1/2 centimeter is enough. Just
Yeah.
to avoid that the skin is touched by the adhesive layer, because this makes like itching.
Okay, brilliant. And I got another question. If the patient has saphenofemoral junction incompetence, would you go above the knee with the wrapping, or would you still until below the knee?
So if he has a saphenofemoral reflux and I treat it like I do
Yes.
envolumina or something, then I would do that after the first decongestion phase, and then he would have a stocking until the thigh. But on the first day, I only would use the wrapping for the decongestion phase, and the edema, the venous edema, is always at the calf. So you don't have to treat the thigh, because on the other hand, if you start walking with the wrapping to the thigh, with a bandage until the thigh, sorry, not a wrapping, a bandage until the thigh, it will, by the best luck, when the patient arrives home, the bandage will be gone. So the over-knee bandages are very, very difficult to have them in situ. And normally the edema is not that high at the thigh. Sometimes if you have patients with a really, for example, cancer, they had a lymphoma in the thigh and they have a real high pressure edema in the thigh, then I bandage them and recommend them to lay down and put the leg up, because every time they stand up, this edema will be reinforced. And I bandage them to the thigh, or I send a nurse to them at home to bandage them, and I give them intensive manual lymphatic drainage. Those are really those where I say this is necessary to do it now and start now, because they suffer a lot. And then you can put a stocking to the thigh. But you should not, for an ulceration, you don't need to bandage until the thigh, even though the reason is in the thigh. Yes.
Okay, brilliant. And if my co-moderator, Dr. Elena or Dr. Mahmoud, have a question you like to ask about the wrapping technique, it's a very nice demo, really, that we rarely used. Do you have any questions or remarks?
I have one question from my side, being working with such patients for many, many years. I think one of the main challenges is actually the compliance also from the patient. So how you see the compliance from the patient regarding the wrapping with the bandage, especially if they need to take showers and change and do things at home? Yeah.
This is why I tell you, other than the guideline says, when you have a soft edema, when you can make a hole in it with a finger, my experience is if I make this bandage, the next day, all this extra water has gone. So I explain them. I bandage you today, or if you can't because you are going to dance this night or something, you come back tomorrow. We leave it 24 hours and have a person for measuring the stocking prepared, and if possible to give you the stocking immediately. So it will be 1 or 2 days with the bandaging. But you can't imagine how many old people in Germany don't want a stocking, but want this bandaging. And I always keep telling, but if you have a stocking, you could walk, you could move, which is at least the highest interest, to keep the people moving and to move the ankle, to have the muscle pump going. But the ancient people want bandaging. And so it takes a lot of time to convince them not to have bandagings. And the young people, they accept, because nobody, I can't believe you. I have this since 3 years and I can't believe you. Next day, we make a picture. We show this massive reduction of volume. It's impressive. Yes. But I would never have somebody with this for more than 2 or 3 days. Just in case you need a flat knitted stocking, for example, and it is not there, or the wraps in Germany, they are not reimbursed immediately. You have to make a request and so on and so on. And then until it arrives, you will have to be bandaged like this. Okay?
Excellent. Yeah.
So then,
I have a,
yeah, sorry.
That's
Sorry
okay.
for-
I have a question. You deal with a lot of old patient, maybe living alone with social circumstances. This kind of wrapping cannot be done by the patient himself. It has to be done by nursing staff or a unit like what you have, a great unit in your place. Is that right?
Yes, and perhaps the reason why they want to be wrapped is bandages is because then at least once a day somebody comes to visit them.
Yes.
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 Perhaps this is the reason.
Yes.
It
Yes.
could be a psychological one. But I tell them always, if you get stockings, and lots of them are not able to don the stockings by themselves, the nurse is coming to don your stocking. But on the evening, you can go and have a coffee with your niece, which you wouldn't be able if you are bandaged. And this is like the psychological way I catch them.
That is why the PhD in psychology is very important, the one that Dr. Elena had. It's very, very important to have this psychological impact of compression. And we know how important compression is to venous ulcer. Any modality, either you're using vacuum, you're using sclerotherapy, all the modality we know are plus compression. And always interesting. Yeah, always interesting how much compression play a role in the treatment and how much other modality play the role. There is no modality that has really got us out of using a nice compression. That is great. Very nice question and very nice demo. I'm very, very happy with this. And we can have...
I
Yes,
go on.
please.
I go on showing things. I'm not finished.
Yes, I know. Yeah.
Okay.
We'll go to the next phase. Yeah, please.
Yes. So a lot of people say, I can't wear a stocking because I wasn't able to put, two things. One, no, I don't wear stockings because I have an ulcer. How can I put a stocking on the ulcer? This is a very ancient, no. I stopped wearing stockings when the leg get ulcerated. And the second thing is if you have a dressing and you put a stocking very unprofessionally, you can have this rolling of the wrap of the dressing. And this is why it is important to use donning devices. And now we will show you, I will put a dressing on the leg and we will show you how with a donning device you can put a regular stocking on the leg. This is, we change to the other image and I didn't forget to stop this. So again, now we put a dressing, the first thing. This ulcer needs dressings. Doesn't hurt me. I don't know, Elena, you will be excusing me for this kind of black ulceration. We need this kind of dressing, but I thought it is blue and white and you will see it perfectly. Of course, you use it with gloves and so on and so on. So this is the dressing applied to the leg. And now, do you see this? Do you see this part here? No. Yes, you see it. Perfect. This is like this. So this is the $1 device. There are lots of speculations what it can be used for, but it is a real wonderful idea. You wrap the stocking around this wobbling thing, and then you have to keep in mind where the back part of the leg is, and there you can see it here, and you go
two side and the ankle.
Excuse me?
The two side and the heel.
Yes, yeah, the two side and the heel. Yes, which is the two side? This one, and this is the heel side. Yes, okay. And then you put like, you adapt it to the leg and you put it very, very smoothly. Of course with gloves. This is always like always. We should have put a glove on. Yes. And normally this one don't stay at the leg of the patient for the whole day. Ah, there are the gloves. Perfect. Britta is prepared. Did lots of you already see this kind of donning device?
Super fast. It takes, I think, like 10 to 15 seconds to apply the stocking using the device.
The wonderful thing, I didn't get the question, I'm sorry, I come back to that. The wonderful thing is that also elderly people can put, when they are wrapped here, they put it on the floor and they go in like this on a carpet floor and can put the stocking on their legs. It is this really great idea. So we put the stocking and we of course didn't move the bandage, the dressing, because we had a very smooth going. So now you can show how to take the stocking off, which is also a little bit complicated. Sometimes, in this case not, but sometimes it is complicated to take this. You just wrap it back. And if it wasn't necessary to wash them, you could just leave it like that for the next day. But normally you should wash it, so you go back to your device and you have one rid of the stocking. This one is a real fantastic idea, but normally patients with ulcerations can use so-called ulcer systems, where you have a very soft and easy to don first system on the leg, and then you put your compression stocking over it. And you know, often people use, I'm back in a second. I have to go here below the camera.
We are getting so many comments, Dr. Erica, about your brilliant demonstration. If you can hear me, can you hear me?
Yes.
And people are really impressed how you did it. You did it really, really quick and easy. You make things looks really, really easy to them.
But they are.
Yeah.
So often wounds are like the dressing is put and then you put something like this to cover it, just to avoid when you put the stocking, to avoid any movement. And now I will show you another possibility not to use this, because it can, as you put it only in this, sometimes it makes like furrows like this. So it is better not to have to fix the wound dressings with nothing, but directly go with, sorry, take back this one you can don it without any other device, because it is a very soft, silk-like stocking. You can just don with your hands. And wait a second. You see it is transparent, it is very smooth, and it makes a fixation of the dressing. And then you have to like be sure it is soft here, and then you put the correct compression over it. And coming back to the question from before, if you would do stockings or compression to a person with very bad arterial perfusion, this is like 12 to 15 millimeter Hg. And sometimes it is enough just to use this if the patient doesn't tolerate more. You can just use this, but you can put the other stocking above it. And the second good thing is that patients can keep this one overnight on their legs, protecting also the dressing, so they can take out the stocking they wear when they are moving, and leave this one on the leg side. And now we have the second one, which glides because the first one is very, very smooth, and the second one slides over it and can be donned without a donning device. And so now you have the two-layer system also, one very thin one below, and this strong compression device over it, and you can't move the dressing because you have fixed it with the first compression device. So thank you. Coming back to here, these are the ulcer kits or Ulcus-Stockings, which I think are a very good idea. I don't know, are they available all around the world?
In Egypt, you can buy the material, but not widely used, and we don't have in Egypt the bandage where you have the rectangle, and with enough compression becomes a square.
Yes.
This one is found all over Europe, but not in Egypt. But I got a lot of very nice comment about your technique, how simple it is, how good it is, how easy. Which one of the both systems that you showed us do you prefer, or when do you use each technique?
I use it one after another. If the patient comes and has an edema, I first take the bandaging.
Okay.
And on the next day, if the edema is gone, I take this one. I go to the stocking as soon as possible, because with the stocking, you fit in your shoes, you can move, you can walk, you can do everything. But if you provide the patient with this kind of stocking and the leg is, let us say, 26 centimeters at the ankle, yes, and the next 2 days, it will reduce to 23 centimeters, you need another size. So the patient or the system has to pay twice for the stockings, or the stocking will be moving and making furrows in the leg, which is counterproductive. So the first, you will use the compression wrapping bandaging if there is a soft edema. You reduce the edema with the bandaging, and these two-layer bandages are so fantastic that you will have reduced the thing within 24 hours. It is great. And the problem only is if they have a severe cardiac insufficiency or a renal insufficiency, you have to perhaps take so-called light systems or only bandage one leg, not to overload the system, or you add a diuretic medication to allow the liquid you have moved out the leg to go through the kidneys. This is important. And you have always to tell the patient, independently on which compression you use, that they have to take them off if they have any pain, if they can't lie down, because if you have a right heart insufficiency, for example, you will not be able to lay down horizontally because you will be short of breath. And so you have to tell them, if this happens, you have to take them off, or you stay like with the thorax elevated a little bit, because it is a very quick thing. After 1 or 2 days, the problem will be solved. Yes.
Yeah. I got another question from Dr. Edwin Stefan. Again, he said, as always, Dr. Erica, excellent presentation and excellent demo as always. But his question comes here. Your comment on ankle movement, because we know that cuff pump mechanism depend on ankle flexion and extension in ulcer healing. What is the role of, he said, physiotherapist in this case?
Yes, there are two moments in the ulcer healing. If you start putting bandages like Elena showed and you put punch graftings, you don't want the tissue movement. And if you start applying dressings that should be on some like this hydro-absorbing liquids and so on, you don't want them to be displaced. And you don't want skin maceration to occur. In these first moments, then you have to avoid a big movement of the ankle. And again, when is a wound giving a lot of liquid? When the leg is thick. If you don't have a lymphedema, you stop, the wound is dry. Yes. So as soon as you manage with bandaging to get the liquid out of the leg, the lymphedema out of the leg, the wound automatically will be drier. And then you can stop moving the ankle. Yes. So this goes hand with hand. With a thick bandage, the movement will be impaired, and with the stocking, you can move. And even though in some moment it would be very important to move, the most important thing is to take the water out of the leg for any healing. And so this part of the bandage is more important than the mobility of the ankle. But as soon as possible, you have to pass from the bandaging to the compression, because the compression gives independence to the patient and gives the movement to the leg.
That is really excellent. Any comment from my co-moderator, Dr. Elena, Dr. Mahmoud? Do you like to ask any question? It's a great opportunity. Professor Erica Mendoza.
I would like to ask you about footwear, because we all know that the kind of footwear patients use, the way they walk. So when we use bandages, especially multi-component bandages, some patients come with slippers or footwear that, I mean, these ankle movements will not be adequate. Yes. So what's your recommendation? What do you do?
I practically do the following. If a patient comes and is alone and has a slipper, I can't put the bandage. Then I say, okay, we make a new appointment, and either you bring, if it's a woman, the shoe of a husband, or you buy a cheap, very big shoe, or you bring somebody with you who will carry you home. And I give them these things you can give for the surgical theater, like plastic bags. Yes, I tell them, okay, we take a day where you have no appointment. You will leave my office with a plastic bag on your foot, go into the car, go home, and don't leave the home until next day, where you come back with your plastic bag on your leg. And tomorrow you will be able to go back to your shoes. So you have to be a little bit creative. Yes. And if a person, for example, which sometimes happens, has like kind of orthopedic shoes, which are very heavily built, you will never have an edema in an orthopedic shoe, because they are so well adapted that the edema is above the shoe. Yes. These kind of patients with polyneuropathies or something that have cripplings in the foot, then you start bandaging where the shoe ends, like above the shoe, because they sometimes have the ulceration above the limit of the shoe. But you always have to be creative with that. And you shouldn't be shy. You just start. Normally you don't harm the patient with bandagings. This is a very big important thing.
I agree.
Okay.
Excellent. And your English is fantastic, Erica. Yeah, your English is as superb as your Spanish and your Italian.
So I just want to go
really fantastic.
To the last step, which I think is really a great achievement in medicine for patients in ulcerations. I had the great honor to be invited by Rahul Jindal to India this summer. And I was very surprised, because in Germany, people have stockings, and the healthcare insurances which pay stockings and wrappings are very, very reluctant to pay the wrappings. But in India, the people are wearing the wrappings for the ulcerations, and they have flip-flops and then the wrap. And I think this is a real good advancement, because you are able to make the same effect like I did with the bandaging, but doing it yourself. So I just would love to present this last version, and then we can discuss every other questions.
Excellent.
We have these wrapping systems, which are self-applicable, more or less easy from one to other enterprise. You have a low cost. And if a German insurer would hear this, they would say, are you stupid? They are so expensive. Yes, but they have a long life. And I always, when I get rejected a wrap by a healthcare insurancer, I write down, this bandage I showed you now, this bandage 6 times plus the nurse doing it is 1 wrap. 6 days wrapping, bandaging is 1 wrap. And they write me back, you shouldn't prescribe the wrap, you should give them lifelong, I don't know, the bandaging. And when I write them back, listen, 6 days bandaging is 1 wrap. And then afterwards, you don't need to do a bandage anymore. Then immediately I get the okay and the go for the wrap. So it will take me months and hopefully not years to convince the healthcare insurances that they should just admit the payment of the reps straight away. And here I copied this from the Sigvaris webpage. This is a little bit of advertisement. I'm sorry for that. I usually don't do advertisements for enterprises, and I show you two different things. One, this is the calf rep, and this is the foot rep. And one very interesting thing I learned in India is they have ulcerations on places I have never seen them. And I will show you where. We go back to the lady. I saw patients, normally the ulcerations of the venous ulcers, also for post-thrombotic syndrome, are somewhere here. These people had their ulcerations here. And this is because they only used the calf rep. I mean, 30 degrees and 98% of humidity is, yes, but if you only wear this, you start making the ulceration here. So it is very important to remind that these systems are not only until here, where my ulceration is pending outside, but you should start at the ankle, at the forefoot with the BRAP system. So my assistant, Britta, is again showing you how to don it. There is also a soft stocking below, which is no compression. Which material? It's baumwolle, yes? Yes. It's cotton, it's washable. This one is really softer than the other one, you see that?
And if you want to apply even compression with the stocking, there are kind of sets coming with compression as well.
There are other sets with compression, you're saying, yes?
Yeah.
Okay.
So there are sets coming without compression and there are sets coming with compression.
Okay. But I think for the easiness of donning, it is good without compression.
Yeah. Yeah.
And now, you see, this one is, are you seeing like here? Yes? Like this part? Yes. Okay. The only one I know on the market that has this one, listen, you can move the foot without fixating this. And this is because you have this part here, which is very soft. And you have a pre-fixation of the wrap already in situ. You don't need more hands to fix it and then finish the wrapping. And I think this is the greatest idea ever because it helps you to don it to yourself. But now we have Britta to don it. There are Velcro-based parts there, and you start like crossing them one to the other side. I mean, there are lots of them on the market. Other ones have smaller, other you can measure the pressure and so on. But at the end of the day, the one measuring the pressure he is able to suffer is the patient himself. And there are PicoPress devices. These devices you can put on the skin to measure. You want to show something? The first time you put them without having any without stretching. And you have these little, I don't know if you see them. You have these like little tesafilms to apply to the skin. And you put it at the edge of the unstretched wrap. So just for the stupids like me, you put it like but just like this, and then you put this strap here, and you have an indication of the compression you would apply. Let me say, like this. You see this stripe here, and then if you want to make a harder compression, you go and make like this. And now you see there, I have like covered the complete strap, and it is 46 millimeter HG. Is it too strong? She's very comfortable. So the wonderful thing with these wraps is that you can like make it very strong, and people, again, 34, yes, people don't suffer. It's very interesting why with the compression stocking with 34 to 46 millimeters Hg, they would say, oh, this is horrible, I can't put it on my leg. But this is I mean, sorry, Mahmoud, I will name another thing. The first time in Bamberg in a meeting, I had, of course, a Sigvaris compression stocking class 2, 25 to 30 millimeters at the ankle. And Mary had the circuit system, and I just put it like I felt, and they measured it, and I added to the 25 millimeters Hg on the ankle, I added 50 millimeters Hg, and I felt like the king. So it is so interesting to see how you can modify and go higher with the pressure without having any negative feeling as the patient. But if you, for example, tell the patient you should go to 20, 23 to 32, this is called German compression class 2, we should adapt it like this. And then, of course, these other tools also. So, to have a digressive compression. But the patient, I'm sure, will not do this every day. This is just an orientation for the first 1 or 2 times, and then he can adapt like he feels. And then we have the foot, which I think is also a very good smooth material. Fitting, I tried this on a meeting, and I fit in my shoes. I had like sporting shoes. I could be able to fit inside my shoes with this one. Of course, slippers will not fit. And my recommendation would always be, especially if you have that ulceration, to use both. Better this one than none, of course, but use both because ulcerations are here. And this foot slipper is so soft and so wonderful. You can, if you have a lymph edema, you can also come until here. And another enterprise, it's Sloman & Rauscher, has a lymphedema toe device. You can put around a wrapping around every toe, which makes it able to be adapted to every situation. But today we were talking about ulcers. In ulcer care, this one is perfect because you need one. You don't have to be changing and wrapping. It is much easier to be donned than the compression stockings. And how are they washed? Can you put in washing machine? Yes. You have to put them inside a net because the Velcro will destroy everything on its way. So you put it in the net bag. And you can wash them in the washing machine. And how long is the half-life? How long are you selling the things? How long do you tell the people they can use it? It is unlimited, because it is not, it is soft, but sorry, soft, but
unfortunately, it's durable and it stays for long. I have seen patients using the same device for more than 2 years.
Yes, yes. So this is, of course, more expensive than buying a stocking. But on the long view, it is much more cost effective.
And it's actually not only one compression device, it's actually combined the 3 different compression levels. So if you want to adjust the compression up or down,
yes,
the patient can still use the same device.
Yes, yes.
Also the size and the measurement is having a wider size measurement. So it also covers wide range of
Mahmoud is being paid to say this.
You know. But you remember in Germany, I challenged Joseph Grace from Australia.
Yes.
Apply it with one hand. And this is what we always talk about, the self-management, because during the COVID, we have learned a lot that we really need to make sure that we give the independence to the patient to be able to do self-management at home.
Yes. Yes.
With the CombaReflex, you have this part, which we call it the third hand, where the patient can use his 2 hands to apply the CombaReflex wraps.
And I tell you, I think the stocking, the smooth thing is wonderful, but the material is so soft to the skin that I, in summer, use it without. I didn't say this now officially, but I in summer used it when I go to meetings and stand all the day I use this thing for my calf without any underneath layer because it is very soft to the skin. It's not itching or something.
Yeah.
Yes. So I think this demonstration you did very well. Thank you, patient, and thank you, Britta, for the for the demonstration. And this is what I wanted to show. Now questions open, discussion, of course.
Excellent, excellent demo again, and there is a lot of compliment from all the attendee with this new device and with how you apply it and the technique. And one of the questions that come to your mind, you can adjust the amount of pressure in the calf muscle different from the one just above the ankle. They don't have to be the same 30 or 40. So you can have like multi-modality situation of compression. Is that right?
Yes. Yes, and like I think Frandoni demonstrated, I'm sorry, one Italian guy demonstrated that that you can put more compression on the calf than on the ankle also. This is especially good in sportive people because earlier we said the highest compression has to be the ankle and so on. And when they came up, these wrapping devices, you said, oh my God, how will you make sure that the ankle will be more pressure than... But it is completely the same. You can put higher pressure on the calf and less on the ankle. And at least the patient will notice when it is not feeling well, and he can just change the pressure. And sometimes it is not so good because they perhaps make it too loose. But even a low pressure is better than no pressure. So even if the patient goes and takes lots of pressure out, you can have an improvement. And coming back to the question before, bandaging the thigh. If somebody really needs a bandage of the thigh, I would always use this kind of devices. You have some for the knee and some for the thigh. And so you can apply them and adapt them as the edema goes back. So you have some situations, you have an acute thrombosis of the iliac vein, then you don't have to start with a wrap. You can bandage them because normally after 2 or 3 days you can go to stocking. But if you have a lymphedema for tumor patients, which is normally those that go to the thigh, the best thing you can do to the patient is really giving them something like this, because he on his own choice can put, when he goes to bed, he can unwrap it. And this is quick. You don't have to call the nurse, wait for somebody making. You can have a shower and rewrap you. And it is the only one that will stick to the thigh when you walk.
Yeah.
Because the bandaging, you have to be really good. Coming back to India, I was invited to see a patient who self-bandaged himself, and he had 5 layers of short stretch bandages, one over the other, and this one managed to stick there. But I mean, it was like this thick, and in these situations, really the wrappings are the kings. I think they will be the future.
Yeah, excellent, excellent. Any question from my co-moderator, Dr. Mahmoud, Dr. Elena? Any question or comments or remarks?
I completely agree with you, Erica. In my clinical practice, wraps are constant, and for elderly people, I do think that they are the perfect alternative for those stockings that are impossible for donning and doffing. And for me, wraps are especially interesting when we have erosive pustular dermatosis due to continuous occlusion because of bandages. So it's a solution to have, when the patient is moving, we put the grafts, and when the patient is resting with elevated legs, we can leave the legs opener, obviously with topical corticosteroids, but this is the solution to avoid continuous occlusion with bandages for leg ulcers. So for us, is a very interesting alternative. We use it daily.
Wonderful.
I think just one comment from my side, because as long as we are talking about the wraps, we have done a couple of studies on the wraps. One of them in Malaysia with a huge number of patients. and we got a huge, really impressive result that improved the healing from 6 months to 6 weeks.
Wow.
Dr. Hari Krishna, I can also share my screen just to make sure that people also see that we have here in the MOH platform, there are different content about the venous leg ulcer, and we do different formats. So there is a one podcast here with top-notch expert from the wound care community, and Professor Hari Krishna Nair from Malaysia did a huge big study there with I think the hospital having more than 5,000 beds or something, huge big hospital there, and they discussed all the results. You can watch here or listen to the podcast. We have also get some cases from Europe, also using the venous leg ulcer tools like the compression wraps from Austria, from Slovakia, from Greece, and all these cases actually using different devices and different things, but also seeing different patients. The good thing about the MOH platform here, you can just need to register to make sure that you receive all the newsletter, and you will see more than 100 of speakers from around the globe for already part of the MOH, with also studies, documents, and different format as mentioned. So you will see here the essential, which is like small interviews with big leaders in the compressions, 10 minutes videos, specific questions related to the compression from Edward Rabe, from Giovanni Mosti, but also we have the Polita, which is a magazine every 6 months, twice a year, full studies, and also the Connect, plus the summaries after each event. We write down presentation summary, so you can also read it if you don't like to hear or listen or see me in the videos. But it was really, really interesting, especially the study that we have done in the ComboReflex with the venous leg ulcer. I think very, very interesting to see it. And if you want to have it as a hard copy, please reach out to our team. They will be more than happy to give it to you. But before we close, also, I would like to hear from all the experts here a take-home message after all this insightful discussions and the comments and the questions coming from the audience. Would be really great if we can get 1 minute from each one of you, just giving a take-home message to the audience to know more about that. By the way, I forgot to mention that we were for the first time live transmitting in different channels, like also the YouTube, but also here in our platform. What is it? I can just show it here. Maybe it's really important also to know that we were live here, as you can see. People can see that here. For the first time live transmit. So we are trying also to make it easy for people. If you cannot register, you can just watch live on the YouTube or on the web page, but also on our LinkedIn page. So please follow, subscribe to the newsletters to make sure you are up to date. So now to the experts to give us a take-home message, starting from Dr. Erica Mendoza.
Thank you so much again for the occasion. Compression is important on the calf, always for the ulceration patients, and you should give them as much as possible and as little as needed to have the compliance going. And sometimes you have to start with the bandage and then adapt compression. Or if you have a situation that you can give the patient a wrap right away, I would always directly give a wrap, because you can adapt the pressure. Thank you.
Thank you so much, Dr.
Dr. Erica, Dr. Elena.
The best dressing for a wound is the skin. Those wounds that are having a good evolution don't need cleansing or debridement. So once you've grafted a wound, just try to space out dressing changes. Changing a bandage does not mean changing the dressing. You can put another bandage, leave the dressing in place if you have that direct and indirect signs of good evolution, and think about a physiological wound healing, not to impede wound healing if you have signs that it is having a good evolution. That's the less you can a wound that is having a good progression.
Okay. And
Muhammad.
thank you very much for the kind invitation, Dr. Mahmoud. I've learned 2 great techniques, how to apply compression, how to do punch graft to the skin. They are so valuable technique to treat a lot of chronic problem, to improve quality of life. And I did learn a lot from this webinar. I would like to thank everyone. And the mic is back to Dr. Mahmoud.
So at the end, thank you very much to everyone, to the speakers, but also to our audience and attendees. We got also so many questions in the live streaming. Unfortunately, they cannot be actively participating because they are not at the webinar, but we will send this question to you, Dr. Erica and Dr. Alina, and we'll get back to you with our answers. Special thanks also to Dr. Omar, my also co-moderator in most of the events. Really, really appreciate it. And I truly enjoyed this event today, learned also a lot as always. And before we close, again, I just would like to mention and remind everyone, please go to the Medical Online Hub platform. It's free, accessible. We have done more than 100 different activities since we started in 2020 with the COVID-19 and thrombosis event with Joseph Cabrini and big names. So you will find a lot of materials in different format. I'm sure also easy to navigate different indications, and we'll be happy to also receive any inquiries from your side or reach our team to know more about the products or the studies and the research have been done on this topic. So thanks so much, everyone. Hopefully we will meet again very soon. Please stay safe, stay healthy, and I'm looking forward to our next event. Thanks so much, everyone.